I'd like to turn to address a list of common concerns about treatment that we've heard from the community. So I'd like to get your take on these. There's nothing that can be done about advanced prostate cancer. Is that true?
So that is very much untrue in that even patients with pretty advanced prostate cancer, even what we call high volume kinds of prostate cancer, can live for years and years and years with appropriate treatments. The concern oftentimes is that the way that we get those years and years and years are with treatments that lower levels of testosterone. And I'm guessing that some of your questions coming up are related to concerns around side effects of treatment. But many of our patients tolerate those side effects pretty well and can live quite a good and vigorous and fulfilling life, even with pretty advanced prostate cancer.
The next one, clinical trials are a last resort treatment option.
Yeah, so as I mentioned before, clinical trials can be appropriate anywhere along the treatment trajectory of prostate cancer, and they are, often being compared against standards, which are often pretty good, but can we make them better? And certainly participating in clinical trials isn't for everyone, but for a lot of our patients who are interested in seeing if an experimental approach might be beneficial to them, or contributing some knowledge to patients down the line, really do find trial participation to be quite fulfilling.
All right, the next one is prostate cancer isn't genetic, so I don't need to be tested. Is that the case?
No, so it turns out that prostate cancer is actually one of our most heritable cancers. Somewhere between 40 and 50% of the predisposition to prostate cancer is actually genetic or inherited based on family. So the part that's tricky and the part that is hard to maybe explain to patients is that a lot of that heritability is not encompassed in particular cancer genes in the way that many people are familiar with breast and ovarian cancers, which are often linked to genes called BRCA1 and BRCA2. So a small subset of patients with prostate cancer do have alterations in that BRCA2 gene or BRCA1 or ATM or some other genes involved in breast and ovarian cancers. And that does impact potentially their treatments down the line, and certainly is impactful for themselves, their siblings, their children, as far as potentially screening recommendations for other cancers. But oftentimes we'll do one of these tests in patients who have a pretty extensive family history of prostate cancer, and they come out negative, and the patient is very confused because they clearly have a family history, but it's because not all the risk of prostate cancer is actually encompassed in these gene tests that we run.
Okay. The next concern is I'll lose all sexual function when I receive treatment.
So it very much depends exactly what the treatment is and, what's being offered and what the recovery is like. So for example, for patients who go into a prostatectomy and have very good erectile function, it's not inevitable that you'll lose your sexual functioning after a prostatectomy. There is a process, we kind of refer to it as penile rehab of using medications like a Viagra or Cialis to restore the blood flow. You could use certain things like vacuum pump devices to restore the blood flow. And again, it's not inevitable that people are going to lose their sexual functioning after a prostatectomy. Even with testosterone suppression, while it's plays a role in libido and erectile function, it's not inevitable that people lose their libido and erectile function completely, even on these drugs. But certainly more often than not, people will lose their erectile function on testosterone-lowering medications. And so there are alternative ways to get erections, involving again, use of vacuum pump devices or injections that people can give themselves into the penis.